Look, had to get on my grind, ain't got no time to be making excuses. Success in my mind, I hit up Sean when I land up in Houston. Him and Gentry told me, Ayo G, when you chasing your dreams, gotta take that risk, so I stake my chips, put it all on me. It is what it is, put all the chips all on me, yeah. I don't talk too much, put the money up, all on me, yeah. I'ma put 10 bands, 100 bands, millions, all on me, yeah. I'ma put 10 bands, 100 bands, millions.
All right, round 2 with Dr. Hogan. There's so much we didn't talk about on the last one, and I still get so many messages on all this stuff. So I think that going over all these questions is just going to help people open people's eyes a little bit more. I mean, there is some good information coming out lately. Like, they're starting to, I feel like the country's probably going in the right direction, because before, I think people were really sheltered for the information that they got.
Yeah.
Especially about preventative medicine, you know, preventative care or preventive health care, whatever you want to call it.
Yeah.
People were just so used to just getting sick, go to the doctor, you pay money when you're sick, and then that's how it's been ingrained in their head.
Well, and I think even just my training alone. So, you know, you take a traditional training and look at me. I didn't graduate that long ago. It was only 8 years ago, but it's that typical traditional model. You know, you pay a copay, you have this much coverage, and then, you know, what's going to be covered. So a lot of people choose their private insured or insured, like through their companies, and like, what is it going to cover? Is it going to cover this med? Does it cover imaging? That's what drives a lot of, I would say, even the traditional side of medicine and physicians, is that it's driven by insurance companies, unfortunately. And so we become almost hogtied in the sense of care. It's like, okay, you know, you actually need an MRI, but like, do we need to do an x-ray first? Which is just poor care. If, you know, you have torn cartilage, torn tissue, you don't do an x-ray first. That's a waste of money, waste of time. But that's an extra step that they require.
Is it?
I mean, not everyone. So every payer is different. So that's the frustration we have, is that like, when we need something, or we want to, like, I want a specific med for a patient, but it's not covered. So, okay, what do? We downgrade it to something that doesn't work as well. But that's what's covered.
Or the patient can't afford it.
Exactly. So that's the frustration I think a lot of society has, and us as physicians. You're seeing a lot of, you know, uproar, people leaving hospitals, and just, you know, I knew going in, you know, just out of residency, that I didn't want to be restricted in, I would say, my time with the patient. You know, right now, what do people spend 6-8 minutes per patient?
Yeah, it's crazy.
I mean, yeah. So it's driven towards that. I would call it more a sick model, or a treatment model based medicine. Is that if you're sick, here's a script, send you on your way.
Almost everything, yeah.
Yeah, without ever actually taking the time to understand, like, what's the mechanism of action of that chronic disease state. Do we change your nutrition? Do we look at your genetic profile? But it's not covered through insurance. So let's just give you a drug and keep it at bay as long as we can.
I have a couple of friends and their kids are in med school. And even today, I remember he asked him, he's like, "Do you learn anything about nutrition?" "No, we don't really learn anything." It's like 1 hour or something.
So we had one class in med school on nutrition. And it's the complete opposite of what I teach my patients now. I mean, I was very thankful. Like, look, I mean, I think we're all trained the exact same. I do think things are shifting, but, you know, once I got into residency and started seeing, okay, like, you know, can I run this lab? They're like, no, that's too expensive. Like, well, this is the active form of this hormone. Like, why can't we run this? He's like, we don't get reimbursed for that. So
the patient's not getting the best care. It's just whatever's available that insurance will pay for, the best route that insurance.
Yeah, and that's not always the case. But I mean, if we're talking, you know, kind of more of a black and white here, it's not always that way. Yes, I mean, there's some very good payers. I mean, obviously, insurance does come into play, but I do think some of that spending, you know, $1,000 to $2,000, dollars a month.
I spent $8. I didn't know we renewed our insurance policy about 2 months ago for the company, and I never knew how much I was paying. It was $1,800 a month, and I think that's my company contributing a little.
Correct.
Too. So it's like for 4 people that we never use. Almost, and of course I don't use it anyways because I see you, and I haven't been back to a regular doctor since, number one, and then number two, I just need it for if I get shot or I get in a car accident and it's almost like if my house burned down, that's all I need it for. I'm not going to file any other claims.
Yeah.
Like if I could just get a base policy or something.
Well, and I think there needs to be an ultimate change in the structure of how insurance is provided. So I use Impact. Impact Health is more of it's somewhat of a shared program. I'm sure you've heard of like shared programs where everyone puts into the kitty, and then like whenever someone needs it, it's separated out. The reason why I like Impact versus like other companies like Samaritan and everything else is that they actually act like an insurance company. So you go in, you give them your card, they actually call, you can get a copay. I actually had to use it because my son needed surgery. But we pay $650 a month for the entire family. Previously, when I had Blue Cross Blue Shield, I was paying $2,700 for my family. So you talk, $30,000 plus a year when I didn't even utilize it. So that's the frustration. You pay so much, and then to get them to actually cover something, or if they do cover something, is it going to benefit me as a patient? That's the key.
Which sounds like no. It reminds me, the whole medical system reminds me of the traditional schooling system too. It's like, okay, they don't teach health in med school, and then they don't teach you about money in traditional school. It's like, you're not going to be successful here and you're not going to be successful here because they don't teach anybody out.
Oh yeah. I mean, that's like me coming out of residency and opening a private practice. Like, no, was not taught, how to run a practice, looking at billing, money coming in, money coming out. I mean, it's kind of a rough go starting out, but then taking more of that proactive approach, I think it's finally starting to come around. I mean, thankful for like social media, Instagram. People are understanding that much more proactive approach on their health. But when I first opened, it's like I didn't have a single patient. And I'm private pay, like, we're concierge. To ask as a new physician coming out, no one knows my name. I mean, that was a very, very kind of daunting experience. I appreciate it now because you learn so much along the way. But again, I wouldn't change a second of it because I get to spend so much time with patients learning and teaching them. But that's what I love to do. And that's what I think patients need. They need that more proactive approach. But when it comes to our healthcare system, I think we need something that's driven towards either incentivizing patients to do better. If we don't incentivize patients to be healthier, then what's the point? They're like, hey, I'm already paying this much for insurance, so my insurance company should do it. But then you're allowing them to kind of oversee your health versus you being more proactive, if that makes sense.
What do you think the biggest flaws are in the current healthcare system?
I think the biggest flaws are I think insurance companies just don't take enough proactive or even preventative approach. Like if you want a nutritionist, I mean, they're not going to cover it. If you need genetic testing or things that we're actually looking at food testing and things that actually start within the gut, I think that we're so traditional minded. We haven't changed our ways in the last, 20, 30 years. Is that I think that we run blood tests, everything's normal, send you underway. But also I think it's too structured where every provider is like in this box. It's like, okay, like let's say you have a blood pressure issue, okay, and you see your internist or primary care, and he's like, okay, well, your kidneys are a little off, so I'm going to send you to a kidney specialist. So it's like, it's taking that extra step when you're actually, and most interns could actually oversee this. But it's like, I'm in this box and I got to send you to this provider, then this provider. And we're spending so many dollars and so much reimbursement on extra providers when they won't get reimbursed. They're like, well, here, I'm just going to send you over here because, like, I mean, the extra time that I'm going to spend, it's a waste of time where I got 20 patients waiting.
That's what happened to me when I got stuck in the system. I would go to one, they'd look at everything and go, well, I'm just going to have to refer you. Not that it was anything like major, but then I just kept getting referred around. And
that's the unfortunate part of medicine now is that, and it's not all, I hate to blanket it because it's not all like this, but as we've seen, even, I hate to even go through COVID again, but it's like even when we saw through COVID, like how much was restricted based upon treating patients. And now you're kind of seeing that, we're actually taking a way more proactive approach of, whether it's vaccinations, is it going to benefit the patient or is it not? Even just drugs that actually help boost immunity or even help that we saw actually had a lot of benefit when it came to COVID treatments. Everything that even off-label treatments like methylene blue, ivermectin. You couldn't even get ivermectin approved through like a Walgreens or CVS because they were so against it, and they actually gave pharmacists, the ability to kind of deny my treatment when we've seen firsthand that ivermectin actually helps with like viral treatments. It does a lot more than that you're seeing now, even just for anti-cancer benefits as well. We're seeing so many more benefits that come for drugs, but it gets so restricted when things start helping patients, we take it away. And I think that's the hardest part for me as a physician, coming out wanting to help patients and being more proactive and do my job, that you're trying to hog time and almost keep patients more sick or just healthy enough where they don't die. And that's a very, very sad, hard thing for me to say because, again, you want to be proactive and you want the best for your patients.
Well, what's crazy with the people I talk to, most of now that there's information getting out there, like we were at a conference yesterday and just the 3 guys that were sitting next to me were kind of asking questions about it. And he's like, man, I've been wanting to start. I just don't know where to go. And he's pretty, in shape, kind of about 45-year-old guy. He's like, I've been hearing about this. I don't know who to talk to.
Yeah.
And they just have no idea. And so again, people, I think the information is starting to get to them. The second thing is a lot of people don't want to spend the money because they still think of it as an expense because you're used to pay. I'm already paying insurance. I don't want to spend a couple $100 extra on, lab work and all this other stuff. And so just because it's been ingrained, like you go to the doctor, you're sick, you spend money. And so people don't think about it as like, hey, it's going to benefit your life. You're going to feel way better.
Well, the other thing is that it is an extra expense. It's like it's like having, it's having 2 gym memberships or something else. You're like, I'm already paying for this. Like, I don't want to have another membership. Yeah. So you're already paying so much a month.
The problem, the insurance doesn't do anything. It doesn't help you.
Yeah. So it does and it doesn't. And it also depends on like, what can you afford per month? But then it's like, if you go for a cheaper like PPO or even a HMO, and then like, what's your deductible? If it's $5,000, that's a lot of money for a lot of people. And so that's the hardest part of like having insurance. And then when you go to use it, it's like, well, shit, like they won't even cover it. Or if they deny it, most will, I'd say maybe 10 to 15% will actually, go against that denial. That takes a lot of time for staff. Like if we write look, I use traditional medicines a lot. But if it gets kicked back and I need a, authorization, here's my notes, and then they still kick it back. We're spending so much time just to get a med approved that actually works extremely well for a patient. But then most will just give up after the second try. And so like, think about how much time that takes for me to rewrite a note, my staff wasting on the phone, and even me doing a peer-to-peer just to get a med approved that it's not even that expensive.
Is that why you see some places this insurance price is crazy and then the cash price is just so much lower because they have to go, maybe they'll get it, maybe they won't. They go back and forth for a couple of weeks. And
yeah, that's why I don't take insurance. Well, and for me to not take insurance, there's a lot of reasons. Obviously, me, like I'm probably talk way too much, but I think that it does drive the way you kind of, treat as a...
Well, it would, right? If you can only prescribe certain things and they can only afford certain things, then you're tied, your hands are tied to only do that one thing.
Correct.
Or it's like, well, I guess it's better than nothing, so I'm just going to do this. Yeah.
So that's the thing is, a lot of people would just give up. It's a lot of people that take insurance. You have to pay a biller, to bill your insurance. But then if she kicks it back to me, where I'm like, hey, I need to like redo my note to where I didn't mention this quite well, or I didn't elaborate enough. Give me a break. Like if the diagnostic code's in my note, and I submit for it, then a patient should be approved for that drug if they need it. But yeah, it's all driven. And yeah, you can get into the talks of big pharma, and then, you have these 2 people that are in bed together that drive a lot of our healthcare system.
Why do you think the U.S. spends more on healthcare than any other country, but it basically still ranks lower than a bunch of other countries?
I think it's the way we've all been taught and trained. But again, I hate to keep going back to the insurance companies, but it's like if you keep reimbursements or decreasing reimbursements for physicians, for hospitals, for clinics, offices, surgeons, what's going to happen? You need to be able to make up for that loss. So, you end up doing more surgeries, running more tests to make up for that loss. I'm not saying that's the entire, deficit for healthcare, but I do think that we're more of a treatment-based system where it's like, a lot of physicians and a lot of people were trained like, hey, do more, but that's not always the best choice. Running more tests sometimes is a good choice because you're trying to get to the diagnosis. But if you're just running tests and you're not sitting down and listening and talking to the patient, what's your nutrition like? What's your genetic profile like? That's where I think that comes into play. But yes, a lot of the money is spent on administration too. But again, this goes back to administrative services and, think about, yes, we study a lot on drugs and medications that do some good, but then not always benefits the patient.
What can we learn from other countries that are actually have a better healthcare system or that are doing it better than the U.S.?
I think there's a lot of factors that come into this. Like, it'll be very difficult to restructure, I think, the entire healthcare system, but I think that we need to take a better look at what impacts, I think, chronic disease states. You have to look at that preventative process. We don't educate people anymore. We don't cover things that are preventative. You get to nutrition, you teach someone about certain medications, like how do we get you off of medications? And like a lot of countries, I think, especially Europe, Canada, wherever, you have to look at the food sources too. Someone gets cancer, someone gets some sort of a chronic disease or autoimmune condition, what are we looking at? Well, you have to look at the food sources and what we consume and what we put in our bodies. Us as Americans and I think the U.S. in general, we're so used to kind of blowing and going and like what's fast and like what will last on the shelves longer is a big issue. Is food's I think a major player that we need to look at.
I think so too. But it kind of seems like it's finally happening a little bit.
It is. Yeah. There's a major shift in, I think, in a good way to look at. Yes, you can go down the rabbit hole of food dyes and look at additives for foods. A lot of our food structures, there's a ton of ingredients, especially when it comes to food dyes. In other countries, it's been illegal for the last 15, 20 years, but we just keep doing it.
If the chronic disease rates keep skyrocketing and not much else has changed, you would think that it's a big culprit for sure.
Oh yeah, but I feel like everyone's got a blindfold on, or we're not educated enough, and we still think we lean on our healthcare system to kind of help us, but in a way, I think we do need to take a much more proactive approach, like as an individual. But it's hard without the proper education. Yes, we have AI and internet, but sometimes it's not that easy.
They also don't teach you really about your health in school, because you could teach kids all the way up to 18. They'd be really conscious about what they're doing. Yeah. If you taught them every single year.
Yeah. I think they've done somewhat of a decent job of, taking out some of the, I remember the old slushies and vending machines we used to have in our school. So they've done a somewhat of a decent job of pulling some of those things out of schools in general. But I still think some of the food that's served to our kids currently is, it's absolutely trash.
I always see those memes on the internet where it's like the old 1960s and 70s, like they show the beach and then they show like the beach today, and every single person, like there is no big people, it's just all just really healthy looking super thin people. And then today,
well, so you look at it, and I think there's a lot of factors there. Yes, I do think, you pass things down obviously to kids and children. As your exposures and things alter and they change, I think genetics play a role into that, but also environments plays a role too.
But there's a fast food place on every single corner now. Correct. There wasn't in the 60s.
Yeah. Think about, I remember even grew up, like we went through a drive-thrus every now and then, but yeah, we always ate at home.
We did too. My parents always made, unless it was like after sports, we go to like the all you can eat pizza place,
Oh yeah, CC.
Mr. Gaddy's and CC's. But other than that, we didn't eat out a lot. We almost ate, and if we were not
Yeah.
driving home from sports, we ate at home almost every single time.
Yeah.
And is even a regular restaurant we never really went to.
I mean, I think economically, as a whole, as things get more expensive, obviously, affordability of things, goes, it's much more effective for families. So, I mean, like if something's cheaper, I mean, look, I trained in Baton Rouge and we train at a much lower income, area. And so, but it's also a culture thing. I think we hit on this even in our last talk. It's like, if you're raised in Baton Rouge and you're raised in that Cajun way and that Southern cooking, it's rice.
Yeah.
It's that Southern style of cooking. So it is a culture thing, one, but then also the affordability of rice is so cheap and so affordable, and it's quick and it's easy. So you have to look at, and even when patients come in my office, like I see all walks of life. I mean, everything from obviously, single moms that have, 4 kids, they're running their children to, baseball practice, football practice. Like how do I manage her as a patient, and how can I guide her? Like, what's quickest? Chick-fil-A.
What is the on the go, like, if there was a healthier option? I'm sure, because Gentry does the same thing sometimes. And
I mean,
I just ate Chick-fil-A. I was like, I don't know if that really means it's good. But if you're telling somebody to go and stop somewhere,
I mean, gosh,
is there a good place? Like, I eat at Chipotle every once in a while.
I hate to even answer this question because, I mean, I could nitpick almost every restaurant.
Correct.
So
but if somebody's like going and they're driving home from sports and then they have to stop at some fast casual something fast food and just grab something.
So I'll take Chick-fil-A since we mentioned that one. So,
but just like some grilled stuff, or
yeah. So I tell everyone, like, look, if you're gonna do it, I mean, anything grilled is a better choice. Another option is telling them, like, okay, like, you can double your protein and just tell them to leave the buns off. Because if you leave them on, you're more than likely to say, well, I may eat half of it. Or you're like, hey, I'll start tomorrow. So make the best smart choice you can on the worst, I think, the worst restaurant that's presented to you. So you can make a good decision, or at least the best decision you could. It's like going to McDonald's. Like, what do you do?
I eat at Chipotle.
Yeah,
because it feels like it's like, at least it's real food. Well, I mean, I hope it's real food.
Yeah,
but
Chipotle's, I mean, I would say out of like a lot of the places, I mean, again, True Food's probably one of the cleanest, but that's not a quick, easy.
It's not. There's Chipotle's everywhere. There's not a True Foods.
Yeah, so I mean, I have lots of patients that eat at Chipotle. They're like, hey, what do I do? And like, this is the only thing. So I mean, I try to guide them based upon, avoiding the rice, avoiding beans because of all the lectin.
I don't eat those when I go there.
Try to kind of just take away the rice, take away the tortilla chips, take away and choose. I mean, look, they have avocado, they have tons of clean meat, clean chicken. You could pack it full of veggies,
there's
sauces.
Yeah, that's exactly what I do.
There's good options there, but like McDonald's would be a bad choice. But the best way you could like approach that is choose for something that's grilled like chicken. But if you just want a hamburger, for instance, like try to just doing a lettuce wrap
instead of the whole hamburger or whatever.
I mean, like going to Jimmy John's, for instance, they do it's called an unwich. I mean, choosing things like that.
The problem too is the fries and the Coke and the.
What's funny, I mean, they'll get
the bunless burger, but then eat a whole extra large Coke. And
or they'll get a Diet Coke. It's like, let me get a Diet Coke, and then the wheels come off. And look, I mean, we're all human, and you're going to mess up, and it's going to happen. But I think that I love to teach, and I think that's hard for patients. They're like, well, I heard this podcast and this podcast, and then I'm on AI, then I'm doing this, and so that's my job to say, okay, let me rein it in and just let me break it down. And that's the best thing I can do. And I think as providers across the country, our job is to teach and educate. And like I said, I think thanks to Instagram, it's been I think a blessing and a curse, because there's too much information. You have people that have tons of followers that really don't know what they're talking about.
That, and I think where the misconception come in, like, you're right, so much information, but whatever works for the other person doesn't mean it's necessarily going to be right for you. Mm-hmm. And so that's what I found. So between all the people that I know, it's like, yeah, I can tell you what I do, and it'd probably be close to something that I do, but it's not going to be exact.
No, it's just like, your genetics are different than someone else's genetics. Like, how fast you process something versus someone else. Like, do they need methylated vitamins? Do they not need methylated vitamins? So everyone's completely different. But I think that taking it back and breaking it down from a functional standpoint is the key, I think, to making the biggest change in patients. It does take time. And again, that's where the whole insurance, copay thing just doesn't make it worthwhile for physicians to spend time with patients. If I was getting so like, for instance, you take Medicare. I mean, some people need Medicare. Yes, there's secondaries that actually help supplement that income, but some people can't afford the secondary. And so, I mean, the max you can get paid on, a level 4 visit, or a new patient visit, you're looking at $140, $160 for a full hour with a patient that has like 16, different medications you're going through.
Plus your overhead, plus everything.
So
plus
that's the thing, is that you have to
plus
run as a business too. And again, I have kids and my kids go to school, and like my kids have to eat too. So it's like, but you have a full staff you have to take care of. Yeah, you have a biller that needs to help bill your, and then you have someone else that's helping you run patients. And so that's where you cut patients' time down to see more, to cover your overhead, because reimbursements are so
smaller.
I mean, my father-in-law, who's actually not with us anymore, he was my mentor. I mean, he was an internist. Grew up in a small town, but I remember talking with him about reimbursements, and it's crazy when I talked with him about his reimbursements further in practice versus when he first opened. He's like, oh, we used to get 100%, like, all the time. And I understand how insurance companies have kind of backed off on some of it, but for you to either deny a whole claim or bump it down, or actually then if you're sending it for reimbursement, you're rebilling it. You didn't get paid on that initial, so you're a month behind already as a practice. So you think of it just like a business.
Yeah.
If money's not coming in, there's no cash flow.
Yeah, we have some pretty good friends, and he in Austin, and he's one of the top neurologists, and he over the years just smaller. He's like, Sean, I can't. It's literally me and one other person there. I can't. It can't be any smaller. And so he's like, you can't make money, and they just kept reducing things, taking away what I could give my patients. And he's like, I don't want to switch to a cash pay model completely because I feel bad for the patients I've been seeing for so many years. And so he's like in this weird situation where he's like, I almost have to. So I think he did a hybrid, and I think it went really well. I think he was surprised how many people were actually willing to pay the cash pay. Yeah. More than he thought, for sure. And it did pretty well. I think he's doing a lot better now. But I mean, he's like, Sean, it's getting to the point where I almost have to he couldn't get out of his lease. So he's like, I don't need 4,000 square feet anymore. It's 2 people. Well, and that's the hard part of as a provider. Like I said, when I first came out, it's like, I second guessed it so much because it was hard to kind of build your clientele based upon the cash model. But how I grew is honestly sheerly word of mouth. But like any other product in the U.S., if it works really well and somebody feels a lot better, they're going to tell a bunch of people. And if if I like this water and I love it, I'm going to go tell a bunch of people. So if you have a good product or a service, you get a referral. Yeah. Well, and that's the hard part. Like when I first came out, and just like other new physicians graduating and coming out of residency, it's like you're offered a very nice, a very decent paycheck when you're used to get paid nothing. And you see this nice paycheck, and it's like, hey, like, let's sign this contract, work at a hospital. And it's like, sounds great. You got great benefits. Then when it comes to treating your patients, you're like, well, shit, this isn't what I signed up for. Like, I can't do this because they won't reimburse for this procedure. So I have to do this procedure or send them back to another specialist. And then it comes back around again. So much money we're spending and time that's wasted. And when you need a much more like active approach to certain disease states. I feel like there's like pharmaceutical companies making tons of money, and it feels like there's a lot of scientific advances, but it seems like there's still very few cures. Like you don't see, it's almost like you think we'd be able to cure so much stuff by now. Why do you think that the cures aren't out there? I mean, I think that there's, I know there's been a bunch. I'm sure there's a lot of since. Yeah, I think there's a lot of things that are
not kept at bay, but I think that we keep things a little, I would say, not disclosed.
Yeah.
When it comes to advancements in medicine and scientific. I mean, look at how much further advanced other countries are. I mean, yes, we're one of the most advanced countries, I would say, when it comes to medicine. But if you look at certain treatment aspects, like let's just use stem cells, for instance. How much benefit do you get from utilizing stem cell therapy?
I still want to go down there and do that.
So
something comes up every time we're about to go out.
Yeah, so you have other countries like, you have Panama, you have Mexico, you have Germany, you have all these people utilizing stem cell therapy for so many other benefits. Like Riordan Clake's he's done, countless studies for even just muscular dystrophy, and you've seen so much progression, so many benefits, but why don't we have it here? No, we do have it here, but you have to take it out of your own body. And so,
is there any benefit to that?
So there is some benefit. It just depends. Like, you and I had this conversation earlier. I had a really, really good friend of mine. His mom, ended up with multiple myeloma, which is basically just a bone marrow disease state. And the treatment of choice is obviously transplant. You can utilize stem cell therapy to kind of help basically regenerate tissue. But, the direction where she went, took her own stem cells and utilized them for treatment and then build the insurance, $100,000. So if you think about it, we won't get to the scientifics of this, but the frustration I have, you take a cancer patient that, that has a lot of issues, has undergone, quite a few treatments. So even her own stem cells have taken some hits. And so, but you're going to take them out and put them back into the same patient when you could take stem cells from a different tissue type that matches. And again, I won't get into the scientifics because yes, you can have a graft versus host disease, which means that like her immune cells could attack this and it may not take. So again, I won't get into that, but you would have a much better chance of putting a clean stem cell is what I would call that, not an aged person. That's where you would have the most benefit.
Yeah.
This is where like Riordan and all them, they take it, it's placental tissue. So, or just amniotic. So you think about like what the sac of the baby's born in. So you can take that sac and you can actually utilize stem cells from that sac. I mean, lots of people store their own stem cells.
So I recently saw a news article, and I don't think I understand the difference, but FDA is talking about removing the warning label from women's hormones. Is it estrogen specifically, or is it?
Yeah. So there's always been a black box warning when it comes to like HRT hormones. This kind of came out from the old like WHI trial. That was like one of the biggest trials that was female based, and it was discussing treatment therapy with estrogen and progesterone. So what came out of that study was that there was an increased risk for one of the groups for cancer and also stroke risk. So then they kind of basically just blanketed all hormone therapy, putting a black box on all of them. So they're trying to kind of get that removed for a lot of the estrogen-based therapies. I would say I agree with that to a certain extent. And what I mean by that, so there's a difference between synthetic and then bioidentical hormones. So the synthetic hormones that were studied in the big WHI trial, that's called basically just equine estrogen. So you think about horses, that comes from pregnant horses.
Okay.
And so you're taking something that's not bioidentical to what a female normally produces in the body.
Why wouldn't they just use the bioidentical ones?
Well, so it's ease of use, and that was kind of one of the first things that ever came out. But also when you start studying other things and studying other hormones that come from different areas and how they're produced, I mean, sometimes the studies haven't been done long enough to know what's going to result out of it. So I think obviously now it's kind of a catch-22. I mean, you can always look back and say, okay, yeah, we would have done this. But I think, I don't know the entire history of kind of how that came about versus just straight estradiol. But when you mix the two and you mix that with a synthetic progesterone, which is called a progestin, that's, again, not a bioidentical. Those two are a complete disaster together. But if you want to remove the label, remove the black box from a bioidentical, because bioidentical hormones, it's the same hormone that a female produces. So that's where can't say I would put that black box warning on that, because you're giving someone back what they actually need. But you take a synthetic where there's definitely a much higher chance and higher risk for those black box warnings. I would keep it on those, but not take it off all of them, because then you're telling them, hey, they're all safe.
If a woman, well, there's also just a bunch of information coming out on menopause and hormones, and what specific hormones do most women need if they're going through menopause, or like just like an average woman? What are the things that they usually have to take to make their hormones steady and not have the effects of what menopause would do?
Yeah, so I'll kind of go the direction of like perimenopause and menopause. So
I know what Gentry takes. I just don't. I know every woman is different, and then. But is there some stuff that I guess the average woman when they come in?
So most of my patients, I mean, like mine are like from 18, and most patients are around 60s, 70s. That's at the upper end. But if we just took a menopausal female, let's just say 0 hormones. Okay, most females and all females do produce testosterone, estrogen, progesterone. Like females forget the testosterone part. If I'm trying to take a menopausal female and help with that preventative aspect, even if they have, menopausal symptoms or not, whether it's hot flashes, estrogen always, progesterone always, to certain extents, unless they have an increased risk of whether it's breast cancer or ovarian, I'll touch on that in a second. But testosterone as well. A lot of my females utilize testosterone. Testosterone's a big player, not just for libido, but for even just that motivation factor, sleep.
Gentry saw a huge difference when she started taking it.
So you think about even just building muscle tissue. We talk about longevity, preventative stuff. If you can just optimize the females, even just testosterone, their workouts are better. You can maintain like muscle mass, which does help in burning fat tissue. But it also, when you think about longevity, you think about even just diabetes prevention too. I mean, it helps the entire metabolic rate. So all 3 of those hormones are what I'm usually looking at. Yes, we'll touch on thyroid too, but they have to be depleted or symptomatic for me to be able to kind of go down that route. But that's the classic, like, yes, estrogen's one of the most, I think. You
would always look at those first and then everything else.
Yes, I mean, we look at all the hormones when someone comes in. I mean, we look at testosterone, estrogen, thyroid, again, progesterone. We look at DHEA too. And DHEA is just more of that precursor that helps you make more like other testosterone and estrogen. That's your precursor. That's your
DHEA had something to do with the adrenals.
So it does. So it comes from the adrenals. So, but it talks to 2 things. So it talks to testicles and obviously men. It talks to ovaries and females. So it helps with production. So it'd be like you trying to bake a cake without eggs. You can make it, but it's not going to produce.
Okay.
So you can give ingredients, but when the ovaries have shut down, the testicles have shut down, there's no point in giving any DHEA because it's not talking anything anymore.
What about if you're on testosterone replacement? Is DHEA beneficial?
So it can be if and remember, testicular function just doesn't. It's not completely shut off. It will help optimize and with production, but if you come in and your testosterone's 100 or 200, I mean, I'm not going to waste time or waste money giving more DHEA. And my younger patients, 100%. Like I'm trying not to get to that point of where I'm giving them testosterone just yet.
Sure, yeah.
I'm trying to utilize things like ACG and DHEA first. Then you see it kind of like what can I do?
Gentry takes progesterone at night. She's like, it's the best thing in the world. This is the first time she ever started sleeping through the night.
I mean, progesterone's phenomenal. It's I would say, and I actually had this conversation with a patient earlier. Progesterone is, I think, one of the biggest and most underutilized hormones there is. And this goes all the way back to even just young females that come in that are, first starting their cycles at 13 years old. They have disastrous cycles, not all of them. But if they bleed for 7-10 days, they're moody, they're clotting, what do they throw them on? Birth control. But you're already throwing them on a synthetic progesterone when you can just give them a natural progesterone instead of giving them a synthetic, and you can take a cycle that goes from 7 to 10 days and bring it down to 3.
So birth control is just testosterone? I mean, I'm sorry. Birth control is just synthetic
it's a progestin. There's differences. There's combo therapies too that have a synthetic, estrogen in it as well. And then you have IUDs that have some sort of medication in, or you can do a copper. So again, you're already starting them off on some sort of, synthetic hormone at an early age. I have females that come in, they've been on birth control for the last 15, 20 years. And they're scared to come off because they're scared of their cycles. But when instead of throwing birth control at somebody, that puts them at risk for not only cancer and other things like blood clots and strokes, like why not have insurance payers pay for more of a compounded hormone that's bioidentical to what we should be taking? There are a few that are bioidentical that you can send to the pharmacy, but the only issue I have with that is that when I need a specific dosage, like not just 100 or 200 of progesterone, what if I need a 150 or I need a 125? Like, that's why I like compounded bioidentical progesterone.
Hey, everyone. I wanted to thank you for all of the support that you've been giving us with the podcast. And if you don't know me, my name is Sean Lynch. I'm a business and real estate guy. And around the age of 36, I started having some health issues, and functional medicine absolutely changed my life. It didn't just fix my problems, it made me feel better than I ever had, even before things started going wrong. I work with a one-on-one concierge medicine doctor. And traditionally, this type of program was really expensive and out of reach for most people, or they didn't know where to start. But that's why SuccessRx partnered with Dr. Hogan to make the same level of personalized care affordable and available to anyone, anywhere in the US. And you'll get access to the same exact program I follow, the one that changed my life. If you want more details, all you have to do is click the link in the description. Thanks again for all your support, and I hope you keep getting value from the show. What about for guys? I've read things about progesterone every once in a while, and certain articles and stuff. For guys, is it no, never?
Yeah. So most, and you'll even hear of this even goes to the estrogen factor. Some guys are always want to even take their estrogen to zero.
Yeah, which is bad too, right?
Completely bad. So guys forget about how much estrogen plays a role in libido. Not only libido, but they think that estrogen only causes just weight gain and just retention of fat and water retention. But it has so many benefits when it comes to just brain health, heart health. There's been more studies on memory, dementia. Even you can even get into Alzheimer's.
Where should a guy be? What's a optimal range?
So we used to be old. Depending on labs, I would tell you kind of more in the middle. So let's just say 60 is at that upper limit. And less than 10 is too low. I'd try to keep between 20 to 30. Sometimes 40 or 50 is a little too high for them because they feel it. They're either emotional or they'll wake up and they have a little bit more water retention in their hands. You got to gauge it on symptoms too. But to give you a gauge, I'd say between 20 to 30 is a really good dose. And you can use several different things. You can take natural DIM, which is just what's in cruciferous vegetables, and all the DIM really does, it really just helps you metabolize through the estrogen a little bit quicker. Then you have other things like estrogen blockers, like Arimidex. There's one. Tamoxifen I would never use. That's a treatment drug or a chemo drug for females that are coming off breast cancer treatment to keep the estrogen super low.
So guys that don't know much about testosterone, what's a good range that, and I know every single person is different. So I guess what have you seen in patients that most patients feel better on, the range that the guys start to feel better on when they're in their 40s, 50s, 60s?
I would say 40s. Let's use the range 40 to 60. Yes, everyone's completely different. I would say between almost close to 1,000 to 1,250 is a sweet spot.
Is where everybody feels pretty good.
Yes, I do have guys that go 1,300, 1,400. Those are my bigger boys that need more. Yes, I have guys that have an 800 testosterone that feel good, and you have to look at every aspect of it too. I have guys that have 600. I don't feel that bad, but when you start really asking about recovery, how well do they burn fat tissue, how well do they sleep, you have to look at a lot of other factors. But the ranges are way too low. You're looking at, most normals that our range sits in labs is 300 to 1,000. Like 300 is way too low.
So is there any truth? I see, again, I don't know if it was articles or headlines or maybe people just post on social media. Is there any truth to back in the 50s, the average man's testosterone was like whatever, 800 or whatever. And then now that same age is like, 200-300. Is there truth to that? Where now it's just, whether it's food or all these other things are disrupting our system, where like the average American or the average male, their just test is low.
Yeah. So I can definitely comment on that because I see probably 80% female, but I see a lot of males too. So in my practice, I'm seeing so many younger generations come in below T. Like when I say low, 20s, 30s age group with numbers within the 300 to 400 range. So yes, you have to go through the gamut and go through your checklist as far as like, is it a pituitary tumor? What's your consumption? Did like the testicles drop when they should when he was born? But you also have to look at,
I was about to say, what else causes it over time?
So you think of environment. Our environment plays a massive role in kind of how production
and I'm sure food, right?
Yeah, food's, I would tell you one of the biggest
because
ones.
if you don't have, I know it's vitamin D and healthy fats and stuff that are going to be able to help you to produce more testosterone.
Zinc, vitamin D are great adjuncts to kind of help, make more. They're also great with sperm production too, but it's one of those where, our food sources, we all know this. Our soil's so nutrient depleted. But it's also like when you go to Europe and you go anywhere else outside of our country, like, why don't you feel as bad outside of our country consuming different types of food, even though you're eating pasta and you're eating bread, but it's ingredients. It's all about how our bodies process food. But you take it in we've been take it from like a young age to now. Look at how much food has changed over the years. We just touched on this, but we're not meant to process certain types of gluten and certain types of grains, and even just our dairy has been mixed in. Like when it comes to a hybrid nature of casein, it becomes inflammatory towards the gut, and then you start becoming nutrient depleted, that then you can't operate like it should.
Also, if you're overweight, your testosterone is generally lower, right?
So it can. Yes. Just like when you look at a person that's skinny, that you think they're healthy, but it's when you have an obese person or they carry more visceral fat and they're much more inflamed, you're going to affect how the body processes it and produces. There's a lot of factors that go in. There's too many that you could name just, where'd you grow up? Like what was your water source? Where did it come from? Did you drink from the sink? Did you drink?
What about like plastics and is that a hormone? Again, I see people post about that. Is that a hormone
we've gotten
disruptor?
good about removing, certain items from plastics that aren't inflammatory. But people you can go down a rabbit hole of like, what to touch, and you can go down the carbon receipts of like. So I do agree. Yes, certain plastics definitely play a role. Yes, drinking certain tap water. Again, it's fluorinated, and so that can affect a lot of different things.
We've replaced almost all of our plastic in the house with just spoons and just anything.
Yeah.
Those meal prep containers are plastic too. So you're like heating them up in the microwave. That seems worse than anything if you're going to heat it up in the microwave and then eat something.
I think heating anything. I obviously cook and heat my food, but it's just like cooking foods on a high temp. Yeah, I agree. Like you're getting leaching into that food. So I would tell anyone that's like doing packaged foods, yes, try to cook it on the stove if you can. Hot plates, anything like that. Even an air fryer I would lean more on than just tossing in the microwave and just, warming it up with the plastic where they say don't vent. And it's like, you're getting so much that goes into that food, even though it's a clean meal. Even just the exposure from the microwave as well. Can definitely have effect. But yes, like I said, you can go down a rabbit hole. It'll make you like insane.
If we char my steak every night, am I going to get cancer? Because it's really good.
So Yeah,
Like,
I mean,
when
again, we talked about this last time. Like, it's one of those where you have to kind of pick and choose your battles. But yes, cooking meats and cooking things, it does become a carcinogen because you're changing that protein structure of that food that then becomes a carcinogen. Cooking things I mean, yes, even you can go back to even like a sous vide steak, but you still have to cook the steak to kind of get, you can't just. I mean, I eat. I mean, yes, I eat a steak rare, but
yours is pretty rare.
yeah, no, I'll eat a rare. I mean, I'll even do steak tartare, but
I can eat that, but for some reason when I order a steak like that, I can't. It's like really rare. It's hard.
I mean, fillets and I would say tenderloins I can do.
It's just the texture. It's not really.
Yeah, no, I know, and it's hard, but like I said, you have to kind of pick and choose your battles when it comes to certain things. But that's where, again, this goes down to kind of education. But yeah, you have all these people on Instagram and TikTok, and I mean, it's mind blowing the amount of info they're scaring the public about everything they touch in a store. Or yes, I mean, there's some big players that are easy targets to avoid. But I mean, just basic foods. I mean, just getting back to eating.
Just whole foods. If you're going to tell somebody follow a diet, they don't know what to do. There's too much information. It's just like, just eat whole foods that aren't processed.
The other problem with that is it's time. I mean, this is where we differ from a lot of countries, is that we spend more time working for the weekend to work for vacation, and then the kids are all in sports and you're running around. It's like that's where it becomes difficult. And look, I won't even meal prep, meaning I'm not going to sit on Sunday and cook 17 chicken breasts. And I'd rather spend time with my kids. I'd rather spend money. I mean, there's a really good company that I actually use my food. I think I sent it to you. I mean, it's called Methodology. Everything's served in glass jars and everything. And so it's a super, super clean company that utilizes, obviously, my diet structure, because I follow a lot more paleo. But it's a little bit more expensive, but I don't have to cook, breakfast and lunch. Or
cooking is
done.
And cleaning is the biggest time waster on the face of the earth.
Well, it's one of those where, like you said, you want to spend time with your kids, and just taking all that time. But it's even my patients, I have to show them certain recipes and certain ideas. I mean, Pinterest is such an easy concept that there's so much there that you can sit down with the kids and come up with a meal together that it doesn't take you 2 hours to prep for.
Yeah.
Because time is everything.
What about peptides? So, for people that I'm sure most people have heard about them now, but what are they exactly?
So peptides are essentially just a chain of amino acids. So you take a protein that's, you say between 50 to 50, like anything greater than 50 chains of amino acids would be considered a protein. A peptide is anything kind of lower than that, but that's a chain of amino acids. That's what makes a peptide a peptide. Peptides are produced, all over the body. You even have peptide related, even steroid hormones, like growth hormone, insulin. These are all, it's a peptide form, but it's a hormone. So they basically act on a receptor that does something. So, we'll talk several different peptides, but peptides are meant to do something within the body, but it's usually a branch or a corrected, I would say a corrected strain of something that's acting on a very specific receptor to do something.
Signaling your body
Yes.
to do something.
Correct. Just like hormones. Hormones are usually produced by organ systems. So you think about glucagon, you think about insulin, those are produced by an organ system to do other things in the body. Peptides are the same thing. They're just a smaller structure.
I don't think a lot of people out there realize either the GLP-1s are just peptides. And they just because they're branded and
so they only know Ozempic and Mounjaro and
the brands.
So the brands are, and I think when the GLPs were first created, I don't think any one of us knew how much impact that they would have, I would say, in the world of medicine. And what I mean by that is in a very, very, very beneficial way. I think that everyone thought, oh yeah, it's just gonna, help with diabetes.
Weight. Yeah.
Yes, patients lost weight. A very, good amount of weight during the studies. But then you're getting all these other benefits but this goes back to the preventative thing we just talked about in the very beginning of this podcast, is that you take a medication that helps someone that loses weight, controls appetite, that then they're shrinking very, very inflammatory visceral fats, that then decreases their risk for stroke, heart attack, and even cancer.
Yeah, I had one of our business partners, he got on somebody who was able to get off a bunch of different medications like blood pressure and all this other stuff that he was able to get off. So I don't know. I do think there's a lot of benefits.
I mean, there is, and obviously, you have a GLP, then you have a tirzepatide that's a dual agonist. That's a GLP plus a GIP. Now you have a third one that's coming out.
That's what I was. Yeah,
it's called retatrutide. I mean, it's going to be a complete game changer. I mean,
what is it going to do specifically that's different? Because I know I've seen some of that. They're just finishing up like stage 3 trials or whatever.
Yeah, I think they're in. I want to say stage 2. They may be rolling into stage 3. So you have a GLP-1 and you have a GIP, which both kind of acts more on that insulin factor plus the hypothalamic drive of wanting food. Then you have glucagon. The benefit of having glucagon, which again, you would think is counterproductive because glucagon and insulin are both made in the same way from the pancreas to help control blood sugar. The great thing about glucagon is you can use almost like your metabolic burn. You're taking fatty acids and actually using it to drive energy. So you have
to give you more energy.
So it's burning. So it's like a furnace. You're using external fats to drive energy for the body. So like when I say energy, I mean more like ATP production and things of that nature. And so
technically it'll give you a little bit more energy
for sure. Yeah. So if you have a triple agonist there, you have something that's controlling your food intake, and then you have something that's also slowing gastric emptying, so you're a little bit more full, and then you have something that's also controlling glucose, helping with insulin production. I mean, it can really, really change the world of medicine.
I've heard too, I don't know if this is true, where it's more muscle sparing than the original ones. Is there any truth to that? Or
I think where that's kind of come out, I think it's the fact that they're used in the wrong way is where you actually get that muscle mass loss.
Like taking extremely high doses.
So yeah,
then just not eat anything.
Correct. Then that's the hard part, is that when it's finding the correct dose. So when I use it, obviously in my practice, I try to kind of almost microdose it, but
I feel like women already don't eat that much. They probably undereat because they're scared to gain weight.
Correct. But then if they're getting it online or they're not being followed, I mean, we always measure muscle mass. Any one of my patients that kind of comes in, we have to kind of structure that, look at their macros, and base their nutrition on their structure and kind of what they're losing, what they're, because I mean, I've had some where we'll walk through and they've dropped 5 pounds of muscle. I'm like, okay, like what's going on? I'm like, I'm just not hungry. So that obviously means we need to lower the dose.
Of course.
So everyone's dose is different, but you have to start out super small. A lot of people are just titrating up because that's what, that's the original diabetic titration, but you're not diabetic.
You're trying to lower inflammation and lose weight.
Mm-hmm. I mean, it's great at lowering inflammation. Like I have lots of patients that are autoimmune that we use microdoses on, like ankylosing spondylitis, rheumatoid arthritis. There's so many benefits in watching these markers basically go down and symptoms improve. If you can control inflammation, and that's a big term but it impacts your gene expression. So if you have a gene or some sort of genetic predisposition that's acting in a false way, like how can we control what's happening? And that even goes back to food. If you're crushing, if you're crushing cookies, or even I'll just say, even though you use the word like gluten-free cookies, I mean, just because it says gluten-free doesn't mean it's that clean.
So
you have to look at what goes into it. So a lot of gluten-free things are rice-based. I mean, I'm not completely against rice, but again, you're trying to control that insulin spike and that sugar as well. And so if you can control what you put in, then you can kind of control the outcome.
What are the most commonly used peptides? I guess, well, in like a medical setting or a practice.
Yeah, and I mean, and again, like this kind of goes back to our conversation earlier about, I think,
besides GLP-1s, because that's the most commonly used peptide.
Right, and I think that's when it comes to peptide therapies, like again, this goes to the instance of where control of being approved. And I'm going to back up for a second because HCG is like one of the most, compounded. It used to be compounded. Then it went back to Pregnil is one of the most commonly prescribed.
That's all I was going to ask. Is there another name for it?
Yeah. So I use a lot of HCG for my younger males, and it's hard to get, your males approved for an HCG. So like cost becomes a major factor where I don't want to give them testosterone. So like then I have to give them HCG, but I can't get them approved for the HCG. So then the cost is super expensive because we're using much, much higher doses. So, the first peptide I'll go over, that I think everyone's seeing a lot of trend on is BBC.
Yeah.
So BBC 157, I can't remember where or what country it was created in, but I'll kind of walk through the history real quick. It was basically taken and synthesized from a gastric, basically, production. And so if you take a snippet of what the gastric stomach lining's doing, it's always, overturning. It's always like recycling itself. It's a very, very low acidic environment, so it needs to be able to kind of withstand a lot, but it needs to be able to regenerate. So if you take that snippet from the gastric juice and then you inject that same compound into, whether it's, a wound, a torn meniscus, some sort of damaged tissue, what they've seen in studies is it really helps not only help regenerate, but it's bringing in helper cells, just like PRP. PRP and platelets, when you cut your hand open, platelets come in and they stimulate growth factors to help regenerate tissue. And so BPC is highly, highly utilized because it's a great adjunct for inflammation. And so you can combine that with also what's called TB500, and that's also another derivative of something that's produced in the body, which is thymosin beta-4. When you combine the two, they almost act synergistically. They act a little bit differently, and like one's stronger at helping with chondrocyte production, which helps with cartilage. And then there's others that are better for like tendons and like even just damaged muscle tissue. That's where the TB500 kind of comes in.
I feel like inflammation is the cause of a ton of problems that are issues that someone has, or me including. Yeah.
Yeah. And and sometimes like inflammation's good. Like when, if you inject somebody with something like PRP and they get a little bit inflamed, that's almost a good thing because it's almost like flies on trash because it's drawing healing cells to that section of the body. A few others I'll kind of walk you through. MOTC is one. That's a 20-year newer one.
Yeah, I guess because I like NAD so much, what's the difference between MOTC and NAD? Like, what's the mechanism of?
Yeah, completely different mechanism of action. NAD is not a peptide, but MOTC we naturally produce in the body. Like if you're like go outside and do an aggressive run, like our bodies produce. And so what's happening if you inject MOTC, what's been shown in studies, you can take it basically removes and takes fatty acids to drive mitochondrial production for ATP. So you think about energy and like you're recovering, and that's how your body moves and functions. So it takes again peripheral fat and then throws it into the furnace to make more energy for mitochondrial function. So that's why it's like, again, with energy production and everything like that.
What if you don't have much fat?
There's always fat. Again, we all have cholesterol, we all have fat. So it's always being pulled from somewhere. So there's always fatty acids. So it's pulling from somewhere. That's obviously there's a lot of talk on that right now. And there's always a lot of talk on mitochondria. But like to go back to your question, like NAD is different. That's a coenzyme. So if you talk about mitochondria and you talk about the energy house of our cells, we have mitochondria everywhere, like brain, you think about, liver, muscle tissue. So what drives that and what helps that organ kind of function is basically, you're trying to drive ATP production.
Yeah.
And so NAD acts upon that. There's this nice little train that happens. It's called the electron transport chain, but I won't go into it. But if it's activating here, then you're driving more ATP production. So if you can drive more production at the mitochondria, then your body's functioning better. It's taking out the trash and it's making more energy for cells. So if you can raise NAD up and you're raising it for the entire body, then your mitochondria is functioning better. You can take out the trash and detox more. This is why like brain function increases when you take an AD.
Yeah, that's why I like it.
Yeah, I mean focus. I mean,
energy and just everything in general is just better.
oh,
when
absolutely.
You take it.
Well, because it's systemically, beneficial.
So might see if I were to take that, it just create more energy, maybe better.
So more energy.
brain
I mean,
functions.
so a lot of people use it a lot more for more fat burning capabilities, but also if you're driving, mitochondrial production, yes, I mean it does help with energy and
Mine's more
endurance as
for
well.
just like performance and thinking a little bit faster, clearer. That would be the reason I would want to do something.
And there's a lot of things. You could even go like NAD is one aspect. Obviously, creatine's a whole other aspect. People forget about creatine.
I take that.
Yeah. So and some people don't take it correctly. I mean, I always tell people to take creatine like before your workouts.
I do it after.
So the reason why I always say do it before, so you think about doing like a HIIT style workout where you're,
Which I do, and I also work out on empty stomach.
yeah. So if you're trying to get that explosive nature, think about it. Your ATP can only feed so much at a time. That's where that creatine kind of gives you the extra. Think about like you're going for a rep of 10 and you're like you hit 9. You're like, man, you're super gassed. That's where that creatine can actually kind of come in and boost and drive a little bit more of that endurance.
Should I just take half before and half after?
So
Or is there any benefit to taking it
I
after?
don't see a reason to take it after. I would say
Okay.
just take it before and after.
I think
Post-workout, I would do BCAAs.
I can't remember. I guess it just comes from 20 years ago. I think the creatine post-workout was supposed to like rebuild muscle or build more muscle or something.
Yeah. So creatine is not just for those bursts that I was kind of talking about. Yes, it does help with, obviously muscle retention and repair as well. But I would say like do it before to kind of help with your workouts too. Post recovery, again, you have a lot of devices that help with your post recovery.
Oh, I know.
That I would say BCAAs and some sort of protein post, just to kind of
I
obviously
don't
help
take
the
any
tissue.
BCAAs. I think that
Yeah, so branched chain amino acids. Again, we don't really produce those, so that's why they're consumed through diet and also nutrition. So, but yeah, like I said, recovery is a whole nother combo. But
how. So I got the hyperbaric chamber in, and I've been doing it every day.
yeah,
I want to do it forever. What's the protocol that you would do it long term?
are you doing it daily?
I am now.
Yeah, I would say
I know I can't do that forever. It's just more.
Most people starting out, I usually say to start off a little on the lighter end, maybe 3 days a week. I would tell you 5 days a week at the most, depending on kind of like your pressures and also your length of time.
Hour is what I'm saying in there.
Yeah. I would tell you if you're going to do it consistently, like 5 days a week, you can bump that down. There's always that initial phase where you're trying to kind of get to a point where you feel great. And then a maintenance would be a little bit less. I would say about half that time.
I was doing the EWOT, the other auction. I would do the PEMF mat, EWOT, and then the red light bed. I was doing that 3 times a week.
Yeah.
Sometimes 4 if I was in town. But basically, I was doing Tuesday, Thursday, Saturday,
When are you doing it time-wise?
early in the morning before I work out.
Yeah. No, that's about right. If you're doing,
I'm also having to wake up hourly. I'd already got up early, and now I'm up at 4. Or like,
that's a lot to do. I'd say at once, but I'd say if you're doing every modality, then I would say that's fine 3 days a week. That's probably too much before your workouts to do all at once.
okay,
5 days a week.
okay.
Your red light. So remind me again. Does your bed, is it infrared?
Mm-hmm.
Okay. Or is it just red light?
It's what's the difference? 640 and 820 wave, and there's like 4 wavelengths. There are 4 different wavelengths that are in there.
Yeah. So red light's obviously more surface
Okay.
tissue. When you're looking at like mitochondria, but obviously infrared penetrates much deeper.
Okay. So if I order a sauna, I need to get infrared sauna.
Yeah.
Okay.
You wouldn't have. Well, the reason why I like the infrared is, it provides so much more benefit at such a lower temp.
Okay.
When you do a traditional sauna, you have to go 200 plus degrees.
Yeah.
over a certain extended amount of period of time to get that internal benefit. Is
So you're doing, so if I order a sauna, I just only want infrared, and then you don't get it as hot, and then you just sit in there.
because you don't need to. It's like because again, it's like when you walk outside, you're getting UV rays and that penetration. You don't feel or see the rays. Same thing with infrared. Infrared's diving so much deeper because of the penetration of energy. So it's just like, your light spectrum. And so, but yeah, to get the overall benefit for a traditional, that's why you have to raise the temp up just enough to where you're getting that internal benefit.
What's the ideal temperature
For
sauna or infrared sauna?
infrared, so most infrareds, talk about 120, 140.
Okay.
That's kind of the sweet spot of the kind of that detox mode. Most you wouldn't go above that. You can go up to 150s, 160s, but that 140s is kind of the sweet spot, I would say.
All right, that's the only thing I don't have, and I want to order one, but I haven't even looked into it yet.
I mean, Clear Light's a really good brand. There's a few other brands that are really, really good. I'll show you. We can walk through it.
Back to the peptides, what conditions, like health conditions, usually respond the best?
Oh, gosh. When it comes to peptides, again, it's all about learning your patient. But if we were just to take a basic patient, I'm on, let's just take a menopausal female. That's an easy one.
That's true, because a lot of them ask me questions, and I don't know how to answer.
So when it comes to menopause, I always tell how I treat my patients is yes, let's look at nutrition, let's look at genetics, let's look at optimizing hormones. I try to get hormones pretty optimal before I start tossing peptides in, because female hormones are a whole different realm. When you're trying to balance out estrogen with progesterone, it's you can have these waves and you just never know how someone's going to respond. You toss something else into the sink, you're like, well, crap,
you don't know what's
no.
doing what.
So when it comes to menopausal females trying to kind of maintain that muscle mass, help with sleep, because obviously every female that hits menopause, that sleep induction goes down. There's a couple that are really, really good. Ipamorelin and Morelin are probably the most well-known kind of peptides. And what that is, that's what we call a growth hormone stimulator. So it's not growth hormone. What it's doing is it's going to that receptor and basically punching a free Coke machine, and you're getting production of growth hormone. It's really, really good because you're doing it at nighttime, so it does help with that nice deep sleep. There's also CJC 1295. So all these benefits when it comes to improving growth hormone, sleep, muscle mass, cholesterol. You can talk about energy, endurance, cognition. So everything that a lot of females start to kind of,
Have issues with
when they're entering that menopausal state. But that's why I say you can do a lot of benefit by just optimizing hormones, and then peptides can actually be that adjunct we were talking about
to get to the next level.
100%.
Yeah.
Especially with recovery. Again, it's one of those where, if you can recover faster and you feel much better, you don't feel old and achy. You want to keep working out. If you're really, really sore and you're crap, I'm overdid it. You want to sit off 3 days and it's well, crap, let me start on Monday. So then it creates a bad habit.
Yeah.
But that's where the education standpoint comes in.
What are the biggest misconceptions or maybe myths about peptides?
I think a lot of things where people misunderstand them. Some want to, I think, utilize peptides instead of doing hormones, which that's a
or just a cure-all, be-all kind of thing.
Because they're well, I don't want to do hormones because they cause cancer, but then I'll do peptides and take it and make up for all these other benefits. And again, I'll stick to the menopausal side of things. Because again, so when a female hits menopause, there's lots of things that kind of decline. Energy, libido, sleep. You think about even just chronic, even just recurrent UTIs because the vaginal tissue is gone, but taking a peptide is not going to help
all the other issues. Yeah.
So you have to look at the preventative side of it. Yes, growth hormone can also help with bone as well, and osteoporosis prevention, but it doesn't do everything that we're looking for when it comes to that cardiovascular protection too. It can help with cardiovascular, I would say, in an indirect way. Less fat, obviously, and less inflammation does help with cardiovascular protection. But the hormones do so much more, which you can't really compare them head to head. But like I said, that's why I was called peptides an adjunct.
Yeah. So if somebody's out there listening, it's like, hey, always look at your hormones first. Then
Yeah. Well, and it's just sitting down and just like, look, I was trained by, some great mentors of mine that just wouldn't even give us a chart in residency. Like, wouldn't even let us look at it. Because if you look at the chart or you look at numbers, you're going to go in, and be super biased and not even listen to what this patient's even saying. I was learning to just sit there, shut up, don't say a word. Obviously, I mean, it's a conversation piece, and a lot of patients just want to talk. Like they don't ever get to speak about their symptoms and like what's truly going on.
well, also to have somebody that will actually try to fix it and not just give them something for it. It's like, hey, let's figure out why you're getting them.
Yeah. I mean, that's the direction we should, again, to go back to our initial conversation, is that we have to be much more proactive. And I hate to keep repeating that word, but it's like, if we don't, as even providers help become more proactive towards patients, then again, we're going to be in the same just rat race as far as chronic disease states. Cancer rates are going to continue to rise, and we're not preventing anything. And you see healthcare and everything continue to rise as well. We're spending money on all this stuff, and what's really happening? We're not changing much. I mean, like I said, the last kind of 5 years I've been in practice, there's been a massive shift. But again, it's taking that proactive approach as just as individuals too. I mean, if we don't speak up, then it's not really going to change.
What do you think would be if you could predict the next like big peptide, what would?
I mean, honestly, like,
I guess the GLP-1s just keep advancing, right?
They do. And like, I think if we can start even just with the GLP and GIP, like I've utilized them so much in my practice in such a different way. Again, I use them as a microdose or even just an adjunct to something else, even just someone that wants to get off a statin. You can use a GLP and diet nutrition and supplementation versus someone taking a statin where they feel like shit all day and still help, prevent. But I do think retatrutide, I would tell you, is if I had to pick something, I mean, taking these three and maybe adding something in addition, even just adding a different style peptide, that'd be a tough one. But I would probably tell you that's like the next biggest one for sure.
I would imagine so.
Oh yeah. I mean, there's like I said, you've seen such a progressive benefit to so many different disease states with just GLPs alone. Obviously when they first came out, there was this massive craze of like weight loss, then muscle mass. And like, yes, but people are still using it completely incorrectly. I mean, I get patients all the time that are at the max dose and they've lost, 30, 40 pounds, but look at how much they're like, I can't come off because I can't lose weight. I'm like, you have to teach and educate as someone's doing it and pretend that if it ever went away tomorrow, you'd be able to survive.
You'd be all right. Yeah.
Yeah. But it's teaching them how to change habits. And that's the hardest part.
So a lot of people ask me, I get questions all the time. Number one, because it benefited me so much, so I talk about it. But then I get a bunch of questions, and I don't know. I mean, I can answer some of them, but it's definitely not the scientific way. So as far as genetic testing, when someone first hears about it, where do they start, or what specific genetic test do they order, or does it matter?
I mean, I hate to use the word, everyone knows the word methylation now. I mean, like I said, Breck has done a very good job of helping start kind of that process, but there's so many other genetics and genes that go into play that we should be looking at besides just surely methylation. Methylation is not everything.
Yeah.
In the entire body. What I like about what gene tests that we do in our practice, and ours is it's called Fagron. We do a Pro7. A Pro7 covers multiple areas. So you're looking at inflammatory markers, you're looking at methylation, you're looking at mitochondrial function, you're looking at detoxification. You're also looking at some external factors of kind of like how you process, whether it's gluten or if you have some external mold factors as well.
Oh, so you can tell that from the genetic test too.
So you can. And so remember though, when it comes to a gene, and Mark Hyman's done a phenomenal job at this, is that your genes aren't your destiny. It's mainly just what your exposures are of how the gene expression comes around. So again, just because you're fed a gene doesn't mean like, hey, like I have an ApoE gene, like I'm gonna get Alzheimer's on my shit. Like I'm gonna like you start freaking out. The goal of doing genetic tests is to see the map and say, okay, like here's my predisposition, but like what do I need to do from a nutritional side, even just environmental side to help prevent this from turning on or off based on like what the gene is.
Yeah. Or help your body process something the correct way.
Yeah. So when it comes to methylation, yeah, I mean, we do tons of methylation tests, but I like the Pro 7, in my opinion, like I said, what I love about Fagron, that it captures so much more.
Yeah. If you're already going to do it, might as well, because you only do it one time forever, right?
Yeah. Your genes don't change.
Yeah. I would.
And so, yeah, I mean, that's the biggest key factor of like taking each one and saying, okay, like I have this. And then if a patient has a symptom, you're like, okay, like let's do this or put you on this supplement, or what, like let's optimize mitochondrial function with CoQ10. So you have to look at each gene of how it works and like how do we utilize that. I think one of the biggest things that I like about the gene test is looking at, I mean, what's one of the most prescribed things when you think about like SSRIs, you think about Xanax, then like benzodiazepines. And so I think they're overprescribed in a way because someone comes in, they're like, hey, like I've had anxiety, I'm depressed. I'm like, here's an SSRI.
Yeah, that's what happened to me.
Like, yeah. And so you're stuck on this drug for 15, 20 years.
I had it since I was 15 years old. And I never, in the beginning, I just dealt with it. I figured out, I worked out, eat healthy. It like kind of helped, but it was only to a point, and I would still have it.
Oh, yeah.
But of course, nobody ever thought to do any of that stuff. It's more like, oh, well, if it gets bad enough, take this. That's it.
And look, I'm not saying that
there's not a place.
Yeah, and I'm not saying that there's not a place for medications. Like I said, I use medications all the time. You come with a blood pressure of 200, I'm going to treat it with a blood pressure med. My goal is look at genes, look at habits, look at nutrition. How do we fix it based upon what the presentation? That's the key of like what we do.
Yeah.
And so just like when you take an SSRI, like are there genes that you're just like methylation has a big role when it comes to optimizing neurotransmitters, dopamine, serotonin, all these that play a role.
Yeah, it made a huge difference in the way I felt, for sure.
Well, I think that you have to piece it together too. But remember, like when when we first started, you can make someone produce way too rapidly.
Hey everyone, I wanted to thank you for all of the support that you've been giving us with the podcast. And if you don't know me, my name is Sean Lynch. I'm a business and real estate guy. And around the age of 36, I started having some health issues, and functional medicine absolutely changed my life. It didn't just fix my problems, it made me feel better than I ever had, even before things started going wrong. I work with a one-on-one concierge medicine doctor. And traditionally, this type of program was really expensive and out of reach for most people, or they didn't know where to start. But that's why SuccessRx partnered with Dr. Hogan to make the same level of personalized care affordable and available to anyone, anywhere in the US. And you'll get access to the same exact program I follow, the one that changed my life. If you want more details, all you have to do is click the link in the description. Thanks again for all your support, and I hope you keep getting value from the show. Yeah, it made me feel super weird for like a week or so.
Yeah. So,
but then I felt really good.
Yeah. So that's the thing, is that if you push someone too quickly because you're feeding them, like you don't fix methylation like, hey, here's methylated vitamins, I'll see you on your way. You can over methylate, and that's where you can take things like TMG or trimethylglycine, which helps kind of control that aspect of like too much methylation. But that's where you have to look at each one to optimize supplementation and therapy based upon that. But yeah, methylation does so much more than just like, here's some methylated vitamins or we can fix it. You have to look at the other pathways too.
So once you fix methylation though, does your body produce hormones better? Does everything get better? Or is it just the way it processes nutrients?
So it's a lot of factors. So I mean, methylation does a lot when you look at the production, and you look at even just think about just like even just red blood cell production. I mean, like methylfolate, for instance, it can actually help correct DNA repair. So if you can fix that, then yes, your body's repairing itself better. You think about if you're lower, even depleted in methylation, you get an elevated level of homocysteine. And homocysteine is super inflammatory, but it's also very inflammatory towards the heart as well. So if you fix it, then yes, absolutely, like the body makes basically helps break down like inflammatory things better, but it also helps produce like even just glutathione. So if you have more glutathione, which is like the strongest antioxidant like the body that's produced by the liver, then everything's recovering faster and you're able to kind of repair it a lot better. So yeah, I mean, methylation is a big aspect, but I hate to just solely focus on that because that's all but that's all everyone hears is like methylation, MTHFR, but those aren't the only two areas of methylation.
Yeah, for me, if I was doing a test one time my entire life and I could figure out everything as opposed to one thing, then I would do that.
Oh yeah. I mean, like the Pro 7, I would tell you out of all the testing we do when it comes to like genetic testing, like that covers, I would say, a lot. You can do a lot. Then it's like, okay, like if we didn't quite fix the problem, then you have to move to a different area or you expand the panel. So meaning like if you started working on someone's genetic like profile.
I think I did I don't know if it was called a male panel or something.
I think you did. I thought you did do the Pro 7.
I might have. Is there one that I can do more? Or we can get
there's
10 times more or something?
There's only so many genes that have been studied, but I would say that you can expand upon it, even looking at even looking at telomeres, which is like looking at obviously your biological age. I thought we did that, but I thought you...
No, I want to do it. Okay. But you said it's getting more accurate.
Yeah.
Don't freak out if it's, it comes back maybe...
normal of like, hey, like your current age. You always want to be able to kind of obviously be a little bit younger than, what your true biological...
I'd like to know though. I mean, that way if you have a base, then, over time, if you did it again, is it accurate enough to do that? So if I did a base now... I wish I would have done it before I started everything because I'm sure it's way different. But
it'd be good to show kind of what you can do and what you can halt as far as like what your age is.
That's what I'm saying. And if I did it in 5 years from now or 10 years from now, I can kind of see.
Yeah, and I mean the goal of looking at it is just showing kind of how your cells are aging, and so the key is like what else can you do to optimize that?
I read about a peptide, or somebody told me about a peptide that lengthens them, or is it what's the way that you want them to go, shorten or lengthen?
So lengthen.
I
don't know of any
epitalon. Is it epitalon?
So epitalon is that more works on brain function.
Okay. I could have swore somebody said, maybe I don't know. There's so many of them.
So that's more that actually works more and helps you more with that sleep induction.
Okay.
Something about like melatonin. Yeah.
Okay.
I don't know of a peptide out there. Or anything that helps lengthen. It's more prevention of it cutting down and just aging.
We can't have a conversation and not talk about my favorite, NAD. It's still one of the best things I've taken. I mean, all of this stuff helped together. I think if I would have started that before I did anything else, of course I wouldn't probably tell the difference as much as I do now. But I think after doing everything else, then doing that, I'm like, holy shit, it really helped me a lot. Just energy, mental clarity is two of the main things. And just overall, the people that I talk to, they go, just like in general, just in a better mood and more energy.
Yeah. I think when it comes to NAD, I think let's start with, I would say the biggest question is like, what's the best route?
I started with IVs, and and they're extremely uncomfortable. It's a very long time period and it's really expensive.
Yeah.
So I thought that in my mind, it's like, well, it's an IV. It's probably the best way to do it, right? That's my way of thinking in the very beginning. I think before I tried them, before I went to your clinic, it was a little bit before that, I think.
I mean, I agree. I mean, I think that in how I was trained, Conover, so Dr. Conover is actually like one of the, the godfathers of like NAD. And, the way he always kind of teaches it is, and I don't quite do it this way, but just because it's compliance, his problem. 500 milligrams a day for 5 days is like his style of protocol.
Yeah, doing it by ID, right?
Yeah, IB is the best way, I think, to start to kind of raise a baseline.
I thought when you did it that much, they used it for people getting off drugs.
So you can,
or alcohol.
So you can do things of that nature, and we've used it in several patients to kind of help control that aspect, but then it becomes a very customized way of like how do you fight the control, and that can go back to GLPs too. Like GLPs are really, really good at controlling kind of that want of like
craving.
alcohol and cravings. Yeah. But you have to figure out dosing structure. Like for me, I've always done between 500 to 750 a session for patients
with an IV.
with an IV. So the key difference that I think that a lot of offices don't do or people don't utilize is that think of it like exercising. So when you exercise, you're there to also like replete certain things, whether that's BCAAs, amino acids, electrolytes. As your cells are turning over and like it's actually making things work in process, I think you do need to be able to push other things in there like B vitamins, glutathione, because the cells are almost like, again, it's like cellular fitness. They're actually exercising and working out. So you want to replete certain things. That's how I feel like you get the most optimal benefit when someone's naive or hasn't done it. Then you can talk about, okay, after we've done an initial, like, how do you feel? Most people don't feel, I would say, the benefit after, in my patient population, after about the third or fourth. I've had some that need 10, like back to back. And 10's a lot because they can be a little bit uncomfortable at first.
A little. They're a lot uncomfortable.
Yeah, I mean, your first few, I'll say, is and that's why people, I'll never give a patient just one because
they're not going to see enough benefit from it.
Well, only if they're naive. If they've been doing them a long time and like, hey, I want to re-up, that's fine. The reason why is because you're going to do one, and this is why a lot of people are like, hey, I did it and I didn't notice anything. It's because you didn't do enough. If you throw 150, 250 into a bag and you did it like once every 3 months, no, you're not going to notice much of anything because it depends on your age and it depends on what your level is. Unfortunately, we can't test NAD levels because it's always in flux. I mean, it's always being created, it's always being destroyed, it's always being utilized. So it's like, it's hard to kind of just pull a blood test.
So there's no good way to do it.
No, I mean, I think Dr. Conver's looking at some ways to kind of look at some tissue and actually look at ways to kind of just determine a roundabout way. But, with certain data and certain studies, we have seen that it does decline with age. And usually by middle age, it's about half of what it was when you were born. So to go back to the structure of dosing, once someone finishes like a 500 pack, I would say like just like 5 days of that, then we say, okay, like how do you feel? They're like, hey, I feel amazing. Okay. Then we say, I could do it one of two ways. You can just do one a month, once every quarter. Some people just want to wait to see when they see that decline.
I didn't feel the benefit when I waited a month or two. Whenever I was doing the IVs, I mean, that would feel really good, but after about a week or so, I mean, not that it was bad, but I felt like when it was a month, 2 months, 3 months, like it was too long. Like I didn't really see that much benefit from it.
Yeah, so that's the hard part of everyone's different on how they re-up, but then a very, very beneficial way is just doing it subcutaneously.
Yeah, that's what I did after.
Yeah, I mean,
I almost felt when I started doing that, after about 2 weeks, almost felt better than doing the bag. Only I think just because I was I was doing it every day, not 3 times. And I started 3 times a week, and I really didn't tell it much difference. And when I started doing it every day, I felt way better.
Yeah. Well, and that's the thing is, I think that you have a much more consistent level because you're doing it every other day, or even some people do it every single day.
I do it every day.
Yeah, I mean, how I treat most of mine, between a good dosing structure, I would say is 75 to 150 a week.
Okay,
is kind of a sweet spot.
And then just split up. However, I mean, not a lot of people don't like take shots every day. So
correct. So, but I'll say this: like doing a sub Q, even personally, for me to do above 50 in a single setting, I mean, it's a little intense. But
that and it'll kind of, whenever I was doing it sub Q, if you do too much, it'll leave a little like a kind of a knot for about a day. Yeah, like just like a slight bump for a day.
Yeah, but yeah, I mean, I would say 25, like anything less than that 50, I would say is very comfortable. Like you almost don't notice it, but you will notice that consistent kind of that clarity and energy. And that's why we always kind of do intakes of like, what improved, like how's your cognition, how's your energy, how's your recovery, how's your mood. And so you have to kind of piece it together. But I would say, 75 to 150 is a good dose per week when it comes to a maintenance dose.
Or any benefit to supplements at all?
So I would say yes and no, depending on what they are. Yes, we can go down the rabbit hole of like NMN, NR, and these are, so what these are.
If somebody hated shots, because every once in a while I will get that person that's like, there's no way I could take a shot. And they go, do the pills work just as good? I'm like, actually, I have no idea. But I did take them before I took an AD and I didn't really notice anything. Not that, again, everybody's different, but.
Yeah. I mean, from my like professional opinion, I would tell you that, and we all know this from even just taking supplements. I don't care if it's liposomal or not. Like the absorption rate
It's going to be less.
Yeah. And again, everyone's gut functions different too. Like, how is your gut? I mean, is it leaky? Is it not? Is it inflamed? I would say the oral versions, I'm going to tell you no. There are benefits because, again, NAD comes from, you think about niacin, you think about, NR, NMN. These are all precursors to making more NAD. So your body needs them. I can't say you're going to get the same benefit as you'd get from actually taking NAD. There is, and I actually forgot the company's name, but there is a transdermal that they've come out with that I would tell you that probably has a lot more promising effects than taking something orally. Because transdermal does work. I would say, like, obviously the number one's going to be an IV, like always.
Yeah.
Because you get 100% absorption and
It's not convenient. And
No, I mean,
for most people, and the price is up there too.
Yeah.
Because you have to have a nurse administer it. Somebody,
Correct.
you're in there for 2
I've
hours,
had-
2 hours
Yeah.
plus.
I mean, and what I tell everyone, like, it gets easier. The first couple are a little bit more rough because
I don't know.
Yeah.
It's still uncomfortable. I was doing them, every other
I know
week.
you were doing yours like every other week.
Yeah. It did never get not uncomfortable, no matter how much you did.
I'll say this: when I've paused for a moment, or I've, like, skipped my injections, just been traveling or whatever, and I come back and it's been 3 months, like, I mean,
Oh yeah, you do feel it more.
you definitely feel it, but it almost knows where to go.
What about methylene blue?
Okay.
Because it's one of those things kind of start seeing everywhere now, and it become, a bunch of popular people are talking about it. What are the benefits? Like, how does it work? I know it's a 100-year-old medication, I guess, used to be used for something.
So I'll give you a little bit of history, like, quickly on it. And so, yes, it was, I hate to use the word dye, but first it came out as a textile dye that obviously was our first anti-malarial drug. But as they started studying it and started looking at it and evaluating it a lot more, became to have so many other benefits, and especially from a mitochondrial aspect. Like, you think about hydroxychloroquine, that helps in other areas of, like, autoimmune, but also was one of the drugs that actually helped with COVID. So you can use methylene blue for, like, certain antiviral things.
How does it work for antiviral?
So when it comes to your antiviral and anti-bacterial benefits, it all comes down to kind of how the viruses replicate. So again, yes, if your body's functioning better, it does boost immunity, but it can.
Okay, so it just lowers your chances of getting a viral infection, or
So it
after
does
you
both.
get it will lower a viral infection.
Correct. So it does both. I mean, and you can even use it as also, it's got some great antibacterial effects too. So as a whole, where we're seeing it a lot more common now, because it's used for a lot of different conditions, but I will take a lot of patients off of, like, whether it's Adderall, Ritalin, because they've been on it for so many years, and you get that massive kind of just dopamine kind of reduction, that you can actually utilize this in a way because it does act upon certain neurotransmitters where you're getting more dopamine in that pathway, just like how you get an increase from other agents or other drugs. So it does help the cognition. It does help with focus. It does help, when we talk mitochondria, you talk about energy, muscle function, endurance. So
What's the mental clarity coming from that people are using it for? I mean,
So
is it mitochondrial?
no, that's acting more on kind of that serotonin, dopamine. So serotonin is more on that kind of anti-anxiolytic and also depression. So when you look at it, kind of how a nerve acts, and you're getting production of these little vesicles of, let's just say dopamine, they do get recycled. So you can almost inhibit the recycling. So you're getting more within this nerve conduction. So you're almost getting more production of dopamine. That's how the mechanism of action works. So that's why you get the cognition. That's why you get the actual mental clarity of it as well. There's been so much data on I would say not only dementia but also Alzheimer's as well. So you think about like how Alzheimer's acts when you talk protein plaques. There's been several studies using a 20 milligram for Alzheimer's has shown a significant benefit improvement in cognition, which is no one even talks about this. So obviously you're seeing a lot more rise in, like, that more proactive approach, but also like what can we do and utilize different things that help us without using a certain or specific medication.
There's a lot of brands that popped up on the supplement side of it. What's the difference between, compounded methylene blue and then whatever the supplement version is? Is there a difference, or can somebody take?
So I would say this, like if I usually don't recommend any methylene blue that's like just over the counter. You want things that are tested, and again, I don't care, even if it's a supplement company, there's so many risks that come with the heavy metals and this isn't I never want to actually deter patients, but it's just more of a guidance factor. You want your pharmacy, especially a compounding pharmacy, that does very, very specific testing on that methylene blue, so you're not consuming something that does have like heavy metals in it. All your ones that are processed and I have no clue where they process them from, like the liquids and even the capsules that you can get online, I would just disagree with it.
Yeah.
And it's just using, whether it's a physician you trust or a
There's
pharmacy.
also not that really, there's not much difference in cost at all either, because the way that they're selling it online.
They're super cost effective, but it's like, do you want to put it in your drink and stain your teeth here? Again, it can cause some staining, but definitely you want to use a pharmacy that's reliable, that's done the testing for you.
What about, I forgot to ask this earlier, GHKCU? A bunch of people are talking about that for skin, for just health in general.
Mm-hmm. So there are a lot of benefits. You'll see it in a lot of skin products, even just, hair regrowth. When it comes to reboosting, repairing collagen, everything. So it's phenomenal for skin, and also repair.
But would you want to use it topically specifically for skin, or would you use it? Would you inject it and it would still do the same thing?
You can inject it, and I would say it depends on where you inject it and how much you're injecting. This is where the problem kind of comes in. I just had a colleague of mine have a patient that went to the hospital. I think I told you about this.
Yeah.
Probably 2-3 weeks ago.
Yeah.
For copper overload. So injecting certain peptides sometimes isn't always the beneficial.
Do you think that they were just taking too much of it, or can you just lower the dose? And
you could, but I don't know. Again,
or how do you know how much to take? I guess there's not many.
So this is where the aspect of where you get it from, and this is kind of where some of the regulations come into play. People can get any peptide online, but it's considered study only. So where you get your peptides from and where you get certain aspects from it, that's a huge, I think, big deal. Again, this always goes back to your provider, but I think topically it's a phenomenal product. Even for hair, I would say injectables I kind of avoid. I would never, guide patients in that direction. Just from that's a personal standpoint.
Yeah.
But yes, there have been some great data on injecting it actually for healing wounds and healing, different areas.
Does it have any other benefit besides skin and health?
Skin, collagen repair, it could be anti-inflammatory as well. So it's more on that repair side. I can't say it's not so much on the side of when you compare it to BPC 157 and TB 500, but more, I would say, regenerative factors of collagen, skin, hair. It's phenomenal for those. So you'll see it a lot of hair products. You see it a lot of people would use it in the aesthetic world, even just microneedling.
Yeah, that's what I heard about that too.
So you can combine it with peptides and exosomes and PRP, and you start taking all these regenerative factors, because the ultimate goal is how do you stimulate your own stem cells to repair the area? Yeah, that's really the ultimate what you're doing.
And so when you do microneedling, adding all those things is just going to speed up the collagen production.
So just microneedling alone is great because it's inducing injury to kind of, remember what I was saying earlier about it's sometimes good to have that inflammatory kind of coming in, because it's drawing healing. So you have these kind of little punctate little lesions that are open, and then you bathe it with, some platelets that have great growth factor capabilities. It's going to heal that area a lot faster. And you see you see so much more benefit there. So it's opening a channel that you're bathing with a lot of good product to stimulate stem cells. So
thanks for coming on. Always great information. I could probably talk about this all day long. People might get sick of it, but I could talk to it for.
Well, that's what I tell my patients. I'm probably a big nerd when it comes to. I probably talk way too much, but I think that's.
Not if you're a patient, because you're actually finally getting
answers,
the information. Yeah, it's like I didn't know any of this stuff existed, and so for them to actually have somebody that can help them get to the root cause of their issues is super helpful. So I don't think a patient's ever going to shut you down on talking too much.
For sure. Okay.
All right.
Cool.
Awesome,
Appreciate
man.
it. Yeah.